right, good afternoon. Welcome to Grand Rounds for the Fertitta Family College of Medicine. I'm Don Briscoe, Clinical Associate Professor in the Department of Clinical Sciences. And I'm very pleased to introduce our speaker today, Dr. Lani Ackerman. Dr. Ackerman is a family physician, a clinical professor in the Department of Clinical Sciences, and is the Director of Electives for the College of Medicine. She went to Texas A&M for both undergraduate and medical school and completed her family medicine residency at the John Peter Smith program in Fort Worth. Dr. Ackerman has a certificate of added qualification in geriatrics, a certificate in tropical and travel medicine, and is certified by the American Board of Quality Assurance and Utilization Review. Along with her many career experiences, Dr. Ackerman has devoted about half of her career to working in global health as a practicing physician, clinic director, program director, and department chair. She's worked in China, Nepal, Bangladesh, and Bhutan, among other places. She also has served in leadership positions in multiple nonprofits and NGOs in the US and in other countries. We're very pleased that she's been with the College of Medicine since last fall and is here to present Grand Rounds on the topic of health in the Himalayas and potential partnerships for students and faculty. Dr. Ackerman.
Y'all hear me okay? Oh, wow. Thank you for joining those of y'all who are on Zoom and in person. Always find it difficult to talk to people on Zoom. That's okay. I'll do my best. So the topic today is actually not quite my favorite topic. I told Wendy maybe she can get me to do Grand Rounds. My favorite topic is actually sustainable development, and that's really been the focus of my career. But today I'm sharing really on a topic because College of Medicine let me escape from here for a while, and part of that time was actually meeting with different medical schools and potential partnerships, affiliation agreements for students, faculty, study abroad type things. So I wanted to share those with you. Our objectives today is to take you through and help you understand in the part of the world that's my second home, sort of how the last 35 years have changed in healthcare. And the reason I think that's important for us to understand is a lot of times in global health, when particularly we as Americans go to a less developed, a middle income or low income country, a lot of times we have a certain perspective. And I want to take you through my perspective, which has changed dramatically because the countries I work in have changed. And that impacts our ability to partner with those countries if we don't understand that. Also want to look a little bit of the changing, not only the changing health conditions, but also some of the changes that have helped change in medical education, which are huge. Also, some of the key cultural differences, why whether you, your students, other faculty in your department choose to work in global health, to understand some of the cultural differences. Once more, I'm focusing on my favorite part of the world. But I think this can be applicable really anywhere. Also, ideas and really look at some potential possibilities for any of you or any of our students that may be interested. And finally, just real briefly to touch on one of my other favorite topics is the ethical implications of global partnership. And we can do a whole Grand Rounds on that maybe another time. But not today, we'll just touch it. So this is a map for those of you who are geographically challenged, like many people in the world. When we used to live in Bhutan, people would say, is that in Africa? And I would say, no, it's not. So this part of the world, it's ironic. I am from Texas. I grew up with no mountains anywhere in sight. I do not know why I ended up living so much of my life by the highest mountains in the world, except that I married a guy from Colorado, and I think it's possible that he just prayed. And so when he met me in Texas, he thought, I can't live in Texas my whole life. So we ended up in the Himalayas. This is sort of my perspective on life in the Himalayas. You may be able to identify 3 of my children. If you look closely at skin and hair color, they think they are Nepali. This is quite a few years ago, and this was when the fourth one came along in our backyard. So my experiences that I share with you, many of them are from living life in another culture, learning another language, being an outsider and becoming more of an insider. Cultural differences, that's one of the things I wrote as objectives, but I think even though some places we may go or partner with in global health may be similar, very often the culture is completely different. And in the Himalayas, the culture is very different, literally everything. How people dress, the customs, the mannerisms, the medical care, even the social determinants of health, which I'll refer to, and medical practice is different. And I think it's really easy for us to go in with the idea that we have achieved it. And I think any of y'all who have been in practice, or even those of you who are not practicing medicine, are probably, the US has definitely not achieved it, as far as reaching the ultimate in healthcare. But a lot of other countries think we really have an amazing healthcare system. And we do in some ways. But medical practice is completely different, and medical education is very different. So when we are, as I hope we will be, hosting students or residents from another country or culture, we have to keep that in mind in the same way that when our students go, they may be at a very different level. A year two may not be a year two. A year four may not be a year four. And there may be things our students know really well that their students don't know at all. These are just some of my neighbors, and these are who taught me everything I know, really, was living in the community. And the lady with the necklace at the front, her name is Debbie. I actually delivered her baby on the kitchen floor. It was the first time I ever used a razor blade and a piece of string to tie an umbilical cord. Not the last time. These were other neighbors, many different ethnic groups. The first part of my talk, I'll be focusing more on Nepal because that's where I spent more time and do spend more time there even now. And there's a little over 30 million people, quite a few diverse cultural groups. So let's take social determinants of health. If we're thinking about, okay, how can we partner? How can we have students from places? How can we with our students? How can we maybe develop research? What are some of the social determinants of health that we're looking at? And that is a huge thing on healthcare everywhere. We know it is here. I don't need to go into that. We know that probably it's as important, probably as important as, for example, the blood pressure medicines is social determinants of health that cause hypertension, right? And it's the same in Nepal. So the that I found impacted people, my patients the most, were the literacy. So didn't mention, my husband and I, while we were living there, started a nonprofit organization, and then we started a non-governmental organization, which we still serve as volunteers for. And we've been running that for 25 years. So when many of my patients could not even understand the germ concept to wash their hands, and patients would keep coming back to me, this was where I learned it. And this is important for our students to learn too. So literacy and non-formal education opportunity for women is a huge issue in this part of the world, as in many. Income generation, agriculture, production, pesticides, food security, animal husbandry, economic security, and social migration. So all of these things are things that we have to consider, and these are issues in the Himalayas. I do want to mention, though, a lot of times when people go, and I even know I always get called when people go into Nepal on, like, they're going short term, they'll always call me, oh, what should I know about? I said, things are changing. When I first moved there in 1990, the literacy rate in most of the villages for women was around between 15 and 20%. And that was basic. That was even being able to write your name. Now, in the cities, it's upwards of 80%. So there's been huge changes, and this has impacted medicine too, but there's still social determinants of health. So when we look at us partnering with someone there or them partnering with us, we have to consider, what is it like now? We don't want to go in thinking it's like it was 30 years ago. And I see that a lot in working in global health. People often don't understand the country or area they're working in. Human and organ trafficking is a huge issue, as it is in many countries. Child labor is officially illegal, but basically when all the human rights organizations came in, it just went underground. So we have a lot of issues with economic and migration. So in understanding the culture I think it's very important to understand the religious beliefs of people. And in the Himalayan region, people are very religious. There's many religions. The two most predominant are Hinduism and Tibetan Buddhism. Third growing religion is Christianity, and there's also Jains, Islam, other religions as well. And many people are subsistence farmers. And so when we look at statistics, and particularly I just throw this out because if any of y'all decide you're interested in partnering in research, it's very important to understand that the statistics are extremely variable depending on what part of the country they're from and who gathers them. Once more, life for women. There are many women physicians in Nepal now, but many women in the village still carry animal fodder most of the day on their backs. If you wonder why people have certain prevalent conditions, what can you think is the #1 chief complaint this time of day? Right? But you have to know the culture to understand that. Travel is not as bad as Houston traffic, but different kinds of challenges. You know, at least nobody gets killed by high, fast-moving vehicles. You just might fall off the edge of the road. And roads are a challenge. So when we talk about doing research or looking at medical education or anything in our country, even though we know there's a lot of diversity, say from East Coast to West Coast to Texas, I mean, Texas, we have our own culture, right? But in this part of the world, even though there's only 30 million people and it's a country a third the size of Texas, the geography makes different areas very different. So other changes that have happened in Nepal, as I was meeting with these different medical schools I'll share with in just a little bit that I've known for years, but also just sort of looking up myself on the statistics to share with y'all, is life expectancy at birth, even since the year 2000, has improved dramatically. Now, I just put in more recent data because we don't have as good statistics for many years ago. Health and life expectancy have really improved five years from 2000 to 2019, which is pretty significant. Interestingly, when I moved there, the #1 cause of mortality for women was childbirth. We had one woman died every 12 hours. And then there was huge emphasis on maternal mortality. And now that is still an issue, but COPD is the #1 cause of death in both men and women in Nepal. Bhutan, we don't have all the statistics, particularly from the villages, but in most of the Himalayan region, that's because of cooking over open fires, primarily. You can see the other things. Tuberculosis is still a main killer, but heart disease is climbing up there. Why is it important for us to know? Well, it's important because if we're gonna partner with other institutions, and all we need to know, common things are common. Infectious diseases, we still see a lot of. This is one of my patients, and by the way, all the people I have pictures of gave me permission. She came in with a shoulder presentation. For those of you who are familiar with OB, it means the shoulder of the baby came and that cannot be delivered. And it took her 3 days. She came on a stretcher. And of course, the baby had already died and she had a ruptured uterus as a result. So even from 1990, when I was doing quite a bit of obstetrics in Nepal, actually in Bhutan initially was more in the 1990s, but 901, and that maternal mortality, that's per 100,000, is actually an underestimate. In the remote areas, it was closer, although we don't have really hard data, closer to well over 1,000 women out of every 100,000 that died in childbirth. In 2015, it was only 258. And you may say, well, that's not very good. It's a huge improvement. So things have really improved. I just put up here for your interest some of the Nepal health indicators that have drastically improved over time. Really, most things have. And I left some blanks because we don't have a lot of data on some things. So why is it important for us to know both the political history and really sort of the history of medical education? When we're working with institutions in other countries, or even having their students or sending out our students, I think it's important that we understand how they got where they are. I mean, like, think of the US. We started out with a lot of family medicine docs who did a lot, and then we subspecialized over time. We have the idea of the country doc. Most countries, it was completely different. And understanding that helps us understand how we can partner better. So let's put a little summary in here. The first, I guess you would say, Western allopathic physicians were, not that many years ago. And it wasn't until 2017, that's just a few years ago, that the Medical Education Commission was formed. And I didn't even know it until this last spring when I was there. I was talking to some of my friends and they were telling me, oh yeah, it's such a pain in the medical school. We now have this commission that looks at what we teach. I thought, oh man, they just now got their LCME. 2017, don't we wish? No, I'm just kidding. But anyway, so this is the geography is one of the issues that is a problem for healthcare. And you can see this is why there's a lot of differences around the country. So this is back when I was still training traditional birth assistants, which now actually the government does not, things have changed. Once more, why we have to know about the country that we're partnered with. And we brought in pelvises, I don't know if any of y'all are familiar with Simulades. They make mannequins and babies. And so we were teaching advanced life support obstetrics to the leading obstetricians in the country. And so they gave me one to teach the traditional birth assistants and midwives. And so that's training some of them. And that is just walking on the way to one of our traditional birth assistants' house. And I will just mention that you don't get the full feel of it. I don't have a video because we didn't have videos on our phones then. And you could step through the plank and it was about, I don't know, that low of a river. But this was how we managed OB. Now, times have changed. So if you go to Nepal now, there is some of this, but primarily women will deliver in some sort of health post. And that was a big thing on safe motherhood, primarily for the for having Pitocin. And this is just the lady in the purple. This is an older picture, but back just showing you the transformation of healthcare just in this one country, and this has happened many, many other places, is from super high maternal mortality to not as bad. And the reason I emphasize this is because I see many foreigners coming in. I'm just speaking from experience, for example, in Nepal, and they will talk with disparaging comments about the Nepali system or the healthcare or the medical school. And it really is not healthy. And instead of recognizing all the accomplishments that they have done, which is very important for us to recognize if we're going to partner with people globally. This is just a literacy class. These are traditional birth assistants. This is actually, these pictures are from that we ended up starting, which I won't go into all kinds of details. And the TBA's transformed maternal child health in that country, but now, thankfully, the government and having more physicians is helping. We taught them they learned how to build toilets, learn how to read and write. We still, I'm very thankful, are involved in literacy, just exceeded 27,000 women learning to read and write through the NGO we partner with. And so it's an exciting part. But this is why COPD is still #1. So if we have students that go to Nepal or Nepali students that come here to learn, or if we're working on research, this is one of the big areas, is trying to improve the situation for cooking in the homes. It's better than it used to be. That was one of my little patients who rolled into the fire, quite common, he lost his arm. But then next to it, you see a smokeless stove. And this is a way that you can prevent it. And so that is why I think it's key for our students to understand social determinants of health. It's really obvious in countries like Nepal, but it's really obvious in our country too. We just often don't look. Animal husbandry, you don't think about. The last case I saw of diphtheria, we suspected it came from a diphtheria outbreak among the goats. Organic farming, we have the problems here, but we don't think about children getting into pesticides, and we have that issue. This is showing a field that uses organic farming techniques and one that uses traditional. Another thing I mentioned about understanding where a country is from when we're partnering and where they're going is to know the history. And this is an older picture from our orphanage, and most of these kids were they were little during the Civil War. But now we have children in our orphanage from migration. They go to the Gulf. The parents go to the Gulf and they die. And so when we're looking at healthcare systems, and working with people from different countries, we've got to know what are their social determinants of health. People don't know. They don't even remember about the Maoist revolution. And yet some pictures I'm going to show you in just a few minutes of a medical school that wants to have an affiliation with us was completely run by the Maoists for 20 years. And as a result, the children in that area who are now adults did not get to go to school for 20 years. There was no health care for 20 years. The other picture is the earthquake. Even though the earthquake was in 2015, as was some of the relief work that we were doing, it was in 2015. We've forgotten about that, but guess what? That had an impact on their medical system, on their medical education, on everything in the country. So we need to know the history. So overall, medicine and medical education has dramatically improved. In Nepal, there's now really fancy hospitals. In fact, I was sort of mad I spent so much money on my healthcare insurance because I was like, man, I can get it here for so much cheaper. They haven't got tourism like Thailand and some other countries do, but there are a lot of private clinics, hospitals. Unfortunately, they have the problem of the brain drain because the doctors can come here and earn more. And many of my former students have come here. They even have an insurance program now in Nepal, but you have to be employed. And there's a big variety of care depending on where you live. Access to care. Sort of sounds like our country, only even to a greater extreme. There are 23 and actually increasing medical schools in the country. When we started the medical school I was involved with, there were only about 6. And that was only 24 years ago or so. So the most recent medical academy is one that I'll show you a little more about, Karnali Medical Academy. And the vice chancellor of that school actually had a Zoom meeting with Dr. Span about 2 months ago. They have the unique, I guess you would say, distinction of being probably the most rural medical college in the world and at the highest altitude with some unique problems there. This is another issue we have to consider both in our partnership and if any students or faculty are interested in partnering in Nepal. And this is also true in many countries. For doctors to practice in Nepal, you must be licensed and you may be imprisoned, and they actually have imprisoned some foreign doctors for practicing illegally. And you may say, well, why? Don't they need health care? Well, they want health care, but they have competition, and foreign doctors are seen as competition. And this is the case in many countries where we may detract from the local physicians, which is once more an important thing we have to remember, that we want to build up their medical system, their medical students, encourage them as we learn from them, not take away. In the past, there may have been too many doctors, but now there are too many in the cities of Nepali doctors. They don't really want us there. They do want, however, partnerships. They want to learn from us, and they want us to learn from them. And so how we approach other systems and other health systems really has to be with humility and a desire to learn, not thinking that, oh, we've got the best system. So this is Julico Hospital. This, I had the privilege of, when I came here, there in 1999, at the invitation of the Nepali physician who started it, there was only the 2 of us that had residency training. He had residency training in surgery from Austria, and I was a family doc. I'd already lived in Nepal for a while and spoke the language and had been out in the village, and we had to leave the village due to the Civil War, but wanted to stay on a few more years as volunteers. So it was a 40-bed hospital at that time. This is Julico Hospital now. Okay, changed just a little bit. 230 doctors on staff, all residency trained. I believe there's 10 different residency programs, hundreds of students. And this is last year. So my husband and I are there, and all the other doctors, it's funny, I always laughed at him. I said, you have gray hair. I was your professor. Mine's not gray. Of course, they didn't go and have it highlighted, but anyway. Those are now the leadership, the deans, and everything of the medical school called Kathmandu University Medical School. It's not in Kathmandu, by the way, just sort of funny. So we started that medical school there, and it's just exciting to see. And once more, I also say this because there's multiple clinical opportunities. I sent a couple of my residents there, even when I was in Alaska. They're very open to having medical students. They have multiple partnerships with the University of Vienna because the physician who founded it is married to an Austrian. And so they have a lot of connections with medical schools there. So this is actually a really, really good place for medical students when there are residency programs affiliated. And it's also a good place for research opportunities because they have one of the best outreaches from the emergency room, and they have about 30 different clinical settings around Nepal that feeds into their hospital. They are a community-based hospital. They are not government-run, which gives them a lot more freedom. The other neat thing is that many of the staff, most of the staff speak English. The patients do not, but the staff do. And so this is one of the centers that we are exploring, and hopefully we'll be having an affiliation agreement with soon, both Kathmandu University Medical School and Duli Khel Hospital. This is another hospital and training center. They have residents. They don't have medical students right now. It was even older than Duli Khel Hospital. It was actually started by the Adventists. It was one of the first hospitals in Nepal. It's now been taken over by the government. And the young lady in the picture that I'm talking to there, she's the chief medical officer, and she was one of my students in the first class as a brilliant young woman. And they already have students that come from Loma Linda and have for a number of years. So this is another, she has extended an invitation to our students. It's very safe. Both of these areas are really safe. They're accessible to students with not too bad of a road. And I'll be showing you some of the other roads, but it's really a great experience. And they are not doing as much research, although they're open to that. As some of the other places. So any of y'all interested in global research probably wouldn't be the best, but I think this would actually be, of all the different places, the best clinical rotation site. They even also occasionally will have expatriate physicians there for a couple of months to do training. This is another really good friend, Anup. He's the head of anesthesia, and he is holding the butterfly that had been sitting in a closet because it had broken, and thankfully, due to, I meant to tell Dr. Butler about this. Dr. Butler and put me in touch with the butterfly people, got a hold of them, and we got Anup's butterfly fixed. So he is happily putting in central lines now with a butterfly. So that's him, and he is happy to have students. I have known him since he was about 4 or 5, and he is just a wonderful, wonderful person, an excellent, excellent teacher. So a lot of opportunities for our students. At Share Memorial Hospital, once more, we do need the affiliation agreement, but they are ready and willing for that, and hopefully we can get that. They even have housing. It's only about an hour and a half from Kathmandu and very close to Duli Khel Hospital. So then from there, I'm going to take you to a different part of Nepal. This is actually an institution, the one I mentioned in Karnali region. Nepal is divided into different regions. Karnali is the one that was occupied by the Maoists during the Civil War, and it is the least developed part of the country. And when I say least developed, I just mean it's just very difficult to access. The roads are not as developed. There's not as much healthcare. Literacy rates are lower. Maternal and infant mortalities are higher. It's much more rural. The Karnali region, you can see where it is, and it's got very high poverty rates. The highest, when I first moved to Nepal, the average life expectancy of women in Mugu district, which is in Karnali, was 36 years, to give you an idea. So these are actually slides from Dr. Mongol, who is the vice chancellor, who met with Dr. Span, and it's really exciting. I'm very, very proud of my second home, Nepal, because the government supported this, and I think it's great. I mean, a lot of aid dollars too, but it is a government hospital, and they recently started their first MBBS. So for those of y'all who are familiar with the terminology, in many countries of the world, an MBBS is what we would call an MD, but it's different because they go from high school. So it's usually a 6-year program rather than a 4-year program. And so their MBBS first class will graduate next year. So they're sort of like us. And I'm going to show you, this is actually from Dr. Mongol. And this is how patients get there. maybe. Some of my patients came like this, but most came on stretcher when I was working there. And this particular woman was pregnant. This is how she was carried over 2 to 3 days. That was the only access. And, you know, it's hard probably for most people to realize the hardships of people, but I will say that I think it's really an amazing opportunity for our students to participate and see this kind of thing. And I also think it's an amazing opportunity to be able to partner with these folks. There's a lot of brilliant people who work so hard that are Nepali working there. And for example, a lot of clinical research. There's so much clinical research, but they have difficulty getting this published in peer-reviewed journals because a lot of times English is their second language, and they just may not have the internet access as we have, which is the other thing I think is really important. So I think you get the picture. Okay. That's the road, one of the roads. If you choose to come there and get car sick easily, I'm very sorry. Okay, this is a road. I just put this in here. This actually was from the international coordinator of our nonprofit. She made this, and this is not to Jumla, but this is another part of Western Nepal. And she chose the music, not me. But I want to give you an idea of why there are certain areas I'm not recommending for our students or faculty to go personally. I unfortunately could not take a picture on the way to Jumla because I was bumping up and down so much. To notice a change in the road. Also, I'll make note that most of the drops off the side are about 5,000 feet. You're getting the rocks out of the road so you can go. All right, how many want to volunteer? Okay, so the road to Jumla is 12 hours of that. Whoops. So here we are in Jumla at Karnali Academy of Medical Science. This is morning report. It brought me back to the old days. It was so fun. Yeah, I know, I love the music. I was expecting some Nepali music, and no, we got Texas music. Anyway, it's a really neat institution. So I don't know if anybody can see the X-ray I'm holding up. Is anybody able to see a problem with that? You don't have to be a radiologist. Can y'all see that the bone seems to like not be even aligned? It's like separate. In one day of rounding, I saw 5 supracondylar fractures where the elbow wasn't even close. It's the level of expertise of the orthopedic surgeons blew my mind. And I was like, how did you get that back together in children? Now, this is once more social determinants of health, because in Nepal you have flat roofs and they don't often build things around them. Children are always falling off the roof, falling off different things. There's very few, I guess you would say, child-proofing. So this is a typical rural medical ward. Now, once more, let me point out, if you go to Kathmandu, you can go to the Grandi Hospital, pay lots of money, and it will look similar to a nice hospital in Thailand or in the US. So this is not representative of every place. This is in the most extreme rural conditions. So this is hospital rounds. If you wonder why everybody has their coats on and things under their white coat, is even in April, in the room we were staying was 40 degrees at night. And outside it was colder. It's cold, it's high altitude. So once more, sort of a little bit of a messed up screen, but can you see that the 2 bones of the elbow are not even connected? That is like super common. So the things they have to deal with, and I mentioned this because it's very limited resources. In fact, the X-ray machine had broken the day after this. And the CT machine had broken the month before. And they couldn't get the pieces because they had to be flown in from Singapore, and it takes 4 days to even get to the hospital if you can get a flight, and otherwise you have to go by road. So it's just, all of Nepal is not like this, but the rural areas are very challenging, even for the physicians. This little gal fell, has a femur fracture, and is just waiting in traction till she can go to the OR. This is their medical students. They're very avid learners, did clinical skills teaching while I was there. You notice there's not privacy partitions. Once more, this is a very rural hospital. I have already shared with the leadership, I don't think that they are quite ready for our medical students, or maybe I should say, I don't think our students are necessarily quite ready for this, but I do think that we can start them out in more developed areas. And I think this area is fantastic for faculty partnerships and particularly for research partnerships. So this is a young girl we were examining who had most likely tuberculosis. This is the Dean of the School of Public Health. And I mentioned that because I don't even remember how many publications he has, and many of them are in peer-reviewed journals. And he is a brilliant man. His team is brilliant, and they are on the cutting edge of all kinds of public health research. They also have medicinal plant research, cordyceps, if any of you guys are into botany, or that it's one of the most extensive herbs, plants, whatever you want to call, that's used in many traditional medicines. They do a lot of mountain medicine research, all kinds of opportunities. This slide is actually also from Dr. Mongol, just on the medicinal plant research that they're working on. And they showed me, I don't know if you all remember when you would, even in grade school, you'd get a plant, you'd dry it and put it in a plant press. That's still how they're doing it. But many of these are rare plants, only in that part of the world. 2 areas, they're in Western Nepal and actually in the country of Bhutan. So now I'm going to take you from Nepal, next door to the country of Bhutan. So this is a flight. Can anybody guess what this is? Come on, you guys. What's the tallest mountain in the world? Mount Everest. Thank you. Thank you. All right. So this is flying over Mount Everest. So this is the center of government in Bhutan. I had the privilege of living there back in the days when it was extremely cut off from the world, and was asked to set up a training program for their doctors. Just like we went through a civil war in Nepal and left there after 6 years because of whole family nearly getting killed, we ended up leaving Bhutan in the midst of an ethnic cleansing where my students were being sent to refugee camps. But Bhutan is a beautiful country. They've been through a lot since then. The country has changed dramatically. This was actually the first time we got to go back since 1993. It was like a different world. This is the president and the chief dean, and that's the guy in the picture with me. Y'all probably figured that's my husband. So he is not a doctor. He says he's a doctor by marriage, which means he knows how to answer most questions that people ask me on the phone, and which he does all the time, especially for people from church that call that don't pay. And yeah, I'm kidding. Anyway, he's actually an environmentalist ecologist. But they just started their new medical school last year, and believe it or not, they are very interested in partnering with us and even open to possibly having students, which is really unusual because Bhutan is a very closed country. Typically, they have opened up a lot. They have had huge changes. Their first allopathic medicine actually came through the leprosy mission. One of those was a midwife. She and her husband was a physician, and she actually did my prenatal care with my first child, and they helped eradicate almost completely leprosy from Bhutan. It used to be one of the most common diseases in Bhutan. Traditional Tibetan medicinal practice is still quite big. They have several institutes for health. I had the privilege of teaching when they first started, and then the medical college, the MBBS program was, like I said, just started in 2023. They've gone from having 2 hospitals. They have 178 basic health units and 654 outreach clinics. They have about 3 major hospitals, but Bhutan is small. It's less than 1 million people compared to Nepal, which has 30 million people. So big difference. Exciting changes. Infant mortality from 103 to 49, that was 84 to 2008. Life expectancy has improved a lot. The problem is it's extremely variable. As you can see from the terrain, in the rural areas, it's hard to access. And basic health units may or may not have much there. Just as in Nepal, it all depends on the budget. And one of the problems of getting physicians into rural areas in both of these countries is the same problem that we have in getting physicians to rural areas. The schools may not be as good. They even have the problem of running out of medications after the budget's finished, things like that. So it's a lot of the same problems, but there are a lot of practical opportunities. I just put this in purely to show, if you see in the background, Talk Song or Tiger's Nest, there it is. I just want to show y'all that I did hike up there last month, and it was a lot easier, believe it or not, than it was 35 years ago when there were no railings. So anyway, it is a beautiful, beautiful country. So lots of opportunities. There's 4 different institutions that want to partner. I went ahead and gave this grand rounds because there was an opportunity. We don't have the affiliation agreement signed. I'm hoping we will. Excuse me. But I think just sort of as I want to open it up for questions, also for those on Zoom, for any questions that you have for a few minutes. But I think, you know, I appreciate the opportunity because this part of the world is, like I said, my second home, my second family. I actually gain weight when I eat food in Nepal because I love the food so much. And I feel more comfortable in many ways in a hospital and clinic there than I do here, just because of the impact it's had on me. But I think when we look at hoping to and looking forward to expanding global health opportunities, both for our students and for our faculty, probably the most important concept, I think, that we can remember, whether it's Nepal and Bhutan or any place, is having an attitude of cultural humility, incorporating lifelong learning, self-evaluation, self-critique, recognizing that a lot of people think that we, being from the US, being from a US medical school, that we really have it all figured out. Of course, we know better than that, right? But many people think that. And also to look at ways that we can develop mutually beneficial relationships, advocacy partnerships, things that we can help without sort of tooting our own horn or going by what we think is definitely most important with our potential ignorance of the culture and the situation. So I think there's a lot of ways we can exchange residents when we have them, students, do research, and try to reduce. I think there's really, there's been some writing on it, excuse me, but on global health imperialism. And I would say that was really exacerbated in COVID, excuse me, where I saw the impact of lockdowns on day laborers in Nepal who starved to death because they couldn't labor, and yet nobody really knew how many people were dying from COVID. And this was sort of a global health imperialistic attitude put on the world in other countries without any idea. And we can do the same thing in medical education and research. So I think it's really important that we learn from each other and work together. Also think it's important, all of these potential partners, and I would say any potential partners we have anywhere, need to recognize that US students should not be allowed to do anything that their students would not be allowed to do. And traditionally, this has been a big problem in global health. These particular areas, I know the leadership, and I know they would not allow that. But I think for any of y'all interested in global health, that's an important thing to always look at for partners. In research, to always make sure everyone gets credit for what they do. And I think also, as we look forward to developing global health in our school, is make sure our students are prepared. I think just going abroad does not equal global health, and also does not equal really maximal learning. So I want to end with that, and I'm hoping, sorry, I have to get a drink of water here. I'm hoping someone has some questions, because I actually went through that faster than I wanted to, because I wanted to leave some time for questions.
I do have an online question. Could you speak about the mental health infrastructure in these locations? To what extent would developing partnerships in mental health rooted in our allopathic model be useful?
Great question. So to repeat the question, if I understood it, mental health resources and sort of approach, is that right? And how it compares to ours. So I will say that much as our country struggles with mental health issues, I'll speak primarily starting with Nepal. It's huge. And I've seen an improvement. When I first moved there, there were, I believe, just a handful of psychiatrists. Nobody knew where they were. And most general doctors had no idea how to treat mental health. Mental health was really shunned. It is much better now, but it is, I would say, it's in its infancy stages. There's not really much in the area of counseling. In some of the universities, the master's in social work is a pretty good start. I know I've had some young people that I have known since they were children, and they've told me about what they learned. And they would maybe be somewhat similar to some of our professional counselors in a way. They get a lot of counseling experience. But there's not a lot of mental health. There are some really good psychiatrists that are trying in the cities, so you can access mental health. But in the rural area, there's very little. And the unfortunate thing is, I don't think we can do much going over there without knowing the language and the culture. I do think there's a potential for partnership to help some of their faculty learn more and let them teach what they're doing and really ask questions, but it's a completely different system. Great question.
Thanks, Dr. Ackerman. I guess a related question is, can you think of many unaddressed behavioral health needs when you think about the gaps, in the system, or the lack of practitioners? I guess Bhutan in particular is infamous for high levels of social and emotional well-being, right? So I wonder how you see the unaddressed needs then in Nepal and Bhutan, or maybe in contrast with each other.
So it's very interesting. I will say on Bhutan that they have a very good propaganda campaign. And because I have many dear friends there at high places, I will leave it at that. I can speak on a personal note. But I will say that while they were talking about national happiness and golf course was getting water, that no one in the town had water. And over 10% of the population was put in refugee camps at the same time they were counting gross national happiness. So I think we have to remember that what we see in the publications that governments put out are often not the truth of the people. So that's a comment on Bhutan. Mental health is a huge issue. I actually just did a house visit on a woman, probably been just over a month ago. I had patients that would stop nursing because of their severe postpartum depression when I was practicing there, and that was many years ago. But even today, there is an attempt, just like for us, just like here, the mental health is very tied in with spiritual. And so obviously it depends on the spiritual background of the person. In Bhutan, it's by far Tibetan Buddhism is the #1 religion as far as in numbers. So the Buddhist lamas are often consulted prior to the physicians being consulted, and they're quite involved. And so, yeah, I'm sorry, I'm not giving you a good answer. I would just say there's a mental health need. There's a recognition that there are big mental health problems. There are not a lot of health professionals trained specifically in that area. Not sure if that answered it.
I have another online question. Great presentation. You showed some very poor areas with minimal health facilities, but also showed what seemed to be very good national average health expectancy. How do you explain the apparent paradox?
So, excellent question. I think 2 explanations. One is there is a paradox. Okay, huge paradox. We even see that in other countries. I think it's more dramatic, particularly in Nepal, because there is such a difficulty to access many areas. And the statistics that I shared with you are published statistics. I will tell you from being on the ground and working there, published statistics are not real statistics, okay? It's improved, but it is not improved as much as it looks like. So I think both of those factors, I worked extensively with many of the leaders in public health in Nepal, and they would say the same. So I'm not saying this just myself. And this is always a problem in many countries because remember, they get their aid money based on improvement of statistics. So if they don't improve the literacy rate, if the maternal mortality doesn't drop, if infant mortality doesn't drop, they don't get any more money from UN, USAID, all these organizations. So it's very important that statistics improve. That being said, they have, but that's one reason you see the paradox. And the other reason is because there is a huge paradox in different parts of the country. Yes.
But along those lines, I see the 10 codes, right? That they are determined by the WHO, right? They vary from country to country. So that may explain some variances that you may find out, obviously, in diagnosis, but in particular in there, how then statistics are being gathered and how can we drive any conclusions about any situational diagnosis when there is just no comparing even apples to apples?
Do you mean, you're asking how can we utilize statistics or draw any conclusions from statistics if we don't know if they're accurate? Is that the question?
Correct. Even ICD-10 codes, right? I mean, I'm sure they are not using the same ones. So then how can we use data? I mean, or believe in any data that is coming from there?
It's a great question. And I will say from being involved in this kind of work for over 8 years, I think that honestly, the big differences that happen in these countries are not from the big organizations that get these statistics. It's from community-based grassroots movements because we don't get there. Most countries that are dependent on aid, they have to fudge the numbers. And I'm not trying to accuse anyone. And even if they do their best, it's really difficult. I published with a group out of A&M on organophosphorus poisoning related things that had to do with the mud houses and the organophosphorus contamination of the dirt. And the way we got a lot of our data, we had to collect it ourselves. We had to go to the farmer groups that we worked with and speak to them in the local language. And it's just hard. Like, for example, when they used to do literacy checks in Nepal, and I'm going to use some of these same techniques, they will often judge literacy based on if someone can read one sentence. And that is where they will get some of their literacy rates. And that's not really reliable data. So I think it's hard to make judgments. I think you just have to look at trends and try to get information from several different places and hope that it's somewhat accurate. So not a great answer.
I have a question.
That's a great answer.
Okay.
I have a question. And according to what you have talked, it seems there are some culture and religious barriers. If one of our students will go there, what kind of advice are you going to give him or her?
So that is an excellent question. And that is why that I am encouraging the school that we have pretty intensive preparation program if a student is going to go somewhere. There are good programs out there already that some schools and residencies, already have developed. There's a lot of material, but we need to prepare them. So I think what advice we give them it would be many hours of training, all right? And I think it would be also specific to the region that they're going to go so that they need to know the history. They need to know the medical history. They need to know the educational system. They need to understand a little bit about the social determinants of health. They need to know a few words in the language. They need to know how to just respond in the culture, all these different things. So it's a lot. And that's really the struggle that many medical schools and residencies have had in global health programs, is there's not always ideal preparation. So thank you for asking.
Thank you.
I do have one more online question. How many facilities in Nepal provide what we would call tertiary care in the US? What happens to people who have an MI? Do they get a stent or a CABG?
So this is really rapidly changing. And I'm sorry, I don't know the number off the top of my head. The Kathmandu area has one really good heart hospital. One of the kids in our orphanage actually had one of the first aortic stenosis repairs there about 20 some odd years ago, congenital aortic stenosis. And so they do cabbages. MIs, you're not going to have a door to cath lab time like ours. There's not any JCIH criteria on that. There are international standards. So MIs are managed sort of how we would have managed them in rural areas a few years back. That's basically what I would say. Most facilities do have EKGs. Most, I would say, bigger hospitals. So they can get a stent, they can get cabbage, but the problem is only in certain places. It's very limited. And it's going to be primarily in the areas of high population. There's another area called Dharan in eastern Nepal, but there's only a handful of centers that can do that. Any one last question before we end? I hope this has been interesting to y'all. And I also, one more.
Yes, hi. Very interesting presentation. Be curious just to hear your thoughts since you've spent your life in both of these settings, the United States medical and then the medical situation that you've explained today. What have been some interesting things that you think maybe they do better over there than what we do here? Either very practical, technical things or a more general approach to it. Just be curious to hear your thoughts.
So thanks for asking. I think from a medical school standpoint, medical education standpoint, what I see is they do things that we did well 10 or 15 years ago that we are losing. What I see is the medical education has not lost the emphasis on clinical skills, on spending time with patients, on spending bedside teaching. Whereas what I see now, particularly in undergraduate medical education, is we have standardized patients, we have simulations, but we don't have that one-on-one mentoring as much. We have it, but it's in a different setting. You don't sit around and talk with the patient on the ward about their problems or in the clinic. And I think the other thing is, I feel like we've lost some of the human touch. And to me, many of my colleagues in Nepal and even Bhutan, particularly in Nepal, it's where I've worked with the educators more, is they haven't lost that. I hope we will gain it back here, but I think in our increased technology, I think that tends to take us away from, I guess you'd say, the humanity of medicine. So thanks, guys. I hope this was interesting, and thanks for joining.